Okay, guys, I am going to record day two. This is day two. We're going to be talking primarily about different individuals as it relates to addiction. So, first group we're going to talk about is women in addiction. Again, women with alcohol, abusing and alcohol dependent diagnosis. It's about 4.6 million people or women. Typically, women do drink less than men, but women tend to have more co-occurring disorders along with mental health issues. So, we also talk about how women can metabolize alcohol a little bit differently than men. So, again, this is based on body weight, height, obviously fat, things of that nature. Even things like people who engage in like smoking marijuana. Because marijuana will stick to the fat cells, again, sometimes women will test positive longer for controlled substances than men do just because of the composite of fat that women tend to have more of. Women drinking patterns and alcohol-related problems vary across age groups. The most common is going to be between the ages of 26 and 34. And among women who are divorced or separated, binge drinking is going to be most common among women aged 18 to 25. I will say if you ever get a chance to watch, if you haven't or have or already done it, I think Hulu has a really good series. It's called Single Drunk Female. It's really interesting just to kind of see how again, her addiction plays out as well as her recovery and some of the challenges that she also faces. Young alcoholic women are going to be more likely than non-drinking women of the same age to be victims of assault, have problems with drugs or DUIs, and then, of course, legal issues. To be honest, again, having worked in a prison, again, the prison I worked in was a female only prison. And it's interesting just to see, again, the amount of women we had from the time I started, from the 2 years after I left, again, it grew quickly. And again, a lot of the women there were there primarily because of drug and alcohol related offenses. And again, typically a lot of them were more substance abusing than anything. And again, or substances contributed to why they committed their crime. Middle-aged alcoholic women are going to be more likely to be prescribed psychotropic medication. Drinking patterns and use are going to be very across ethnicity. So again, drinking is going to be more prevalent among white women. And again, and African-American women are going to be more likely to drink heavier than white women or any other racial group. 1970s, alcohol problems among women were recognized as a widespread phenomenon, and this is when we came up with Comprehensive Alcohol Abuse and Alcoholism Prevention, Treatment, and Rehabilitation Act of 1976. Again, this particular legislation gave special consideration to treatment and prevention grants related to women. Women drink in response to multiple losses throughout their lifespan. So again, you think about the reason why or some contributing factors or maybe risk factors that you may want to think about when you are working with specific populations. Again, some of the losses include divorce, death of a parent, especially those women who were who were caregivers, or they had inconsistent parenting as a child growing up. Parents were unavailable or neglectful growing up. So again, we want to look at parental patterns. This is where we look into that biopsychosocial or that social history report and getting those relationships, maybe even looking at the EcoMap or genogram. Again, we also, women who grew up in more violent households or had abuse, those women who experience empty nest syndrome. So again, kids who go off to college or again, leave the home. So again, these are some of the risk factors associated with women drinking or going into drinking more or contributing to their increased use. There's also strong stigma associated with addiction, and women leads to feeling of shame and guilt. And again, this is pretty much with most people in addiction. Again, there is this idea that I should be able to control this or I shouldn't be feeling this. So again, there is some stigma related to this. Many women who have experienced sexual, emotional, or physical or abuse are going to be more likely to develop an addiction. Currently, I believe the statistics is 1 in 3 women have some type of sexual trauma. I think for men, it's like 1 in 6. So again, the idea is the risk factors for most people are going to be there. It's estimated that about 30 to 80% of women were victims of incest. And again, that's a pretty large gap when we look at 30 to 80%. And you have to think about in terms of individuals who are reporting this. Again, people may or may not report their abuse. So that's probably why the statistic is so widespread. So this is going to be a quick video. Hopefully it's quick. But I like this video. I think it does a really good job of, again, talking about or highlighting risk factors and some of the other issues that women face.
My head on. If you would have told me back in 2006 that my boss would become the president of the United States, I probably would have told you were crazy. Most people came to know me in 2006 when I won Miss USA. And even more people got to know me later that year when I tested positive for cocaine. But what they didn't know was that I had been silently suffering from a nasty addiction from the age of 14. And I want to share with you a bit about my journey with addiction. My life was the perfect storm for addiction to manifest. I survived incest at 3. My parents had a rocky relationship, and alcoholism and mental health issues were very present in my family. I grew up in a really small town in Kentucky with a church on every corner, like the type of town where you could throw a Bible and probably hit a pastor on the head. And what was impressed upon me was that if I drank or smoked or had premarital sex, I was going straight to hell. And I remember thinking how unfair that seemed because my uncle didn't give me a choice in the matter. So, fast forward to 14, my parents are going through a nasty divorce. My papa, my protector, and the only person that ever showed me unconditional love dies. And the pain and loneliness that I experienced were truly unbearable. And so when I'm on a cheerleading trip, it's an away trip to Gatlinburg, Tennessee, and the juniors and seniors score a gallon of vodka from some nearby college boys. I was elated when they offered me some because I desperately needed to feel a part of something. So I mixed my first drink, and it was 75% vodka, 25% orange juice, and I chugged it like I'd seen my family do. And then I went back to the counter and I mixed 75% vodka, 25% orange juice, and I chugged that because I wanted to seem like I've done this before, right? My next memory is of me coming to making a deposit to the porcelain gods. And I'm in the middle of this room, and the room looked like this. There were 2 girls fighting in the corner, some sexual acts going on the bed, and there was this poor girl that was in the bathroom and she was crying and she was cutting herself. And I was just like, whoa, I have found my people. Because the chaos in that room looked just like the chaos in my mind. Until the next day when I woke up with the worst hangover of my life. And I was sweating vodka from my pores. And I was a little nugget that they would throw up in the air that would do backflips. And I was terrified that I was going to exorcism style spew all over the audience. And my cheerleading coach was the president of the Fellowship of Christian Athletes. So God was there. And I was so afraid that I was going to get caught. So I prayed to this God that I truly believed wanted nothing to do with me. And I said, hey, big guy, if you can get me out of this one, I swear I will never do it again. And I meant it. I made a firm resolution that day to never touch another drop of alcohol. And by the end of that year, I was hooked on morphine. See, I didn't know that by me having my first drink at 14 was making me close to 40% more likely to become dependent. I didn't know that my brain was going through rapid development. So when my parents would look at me and say, what were you thinking? I wasn't. My brain wasn't fully developed yet, right? And they would bring officers into our school and try to scare us straight with eggs on frying pans. And that wasn't scary. That looked like a good time to me. The average age that kids are drinking these days is 11. They're playing Russian roulette with their lives and they don't even know it. And there's no effective government-funded prevention program nationwide. So now I want to paint a picture for you. If an old man is strung out on heroin living on Skid Row, people assume that he made that choice. When Charlie Sheen is cracked out of his mind, there goes an entitled celebrity, right? When Miss USA fails a drug test for cocaine, what a bad role model she is, right? But when a 14-year-old dies of an overdose, now that's a tragedy. So now I want to talk about how we stigmatize this disease. When I failed a drug test for cocaine and Donald Trump chucked me into rehab, I faced the stigma head on, and people were calling me disgraced Miss USA. TMZ coined Mess USA, which is very witty, and I'm going to use that as the title of my first book. Thank you. Side note, it is also my gamer tag for Call of Duty for all the gamers in the room. And when I left treatment, I had to do a media tour because that's normal. And I had this man ask me, "Do you think you tarnished the crown?" And all I could see was that 14-year-old version of myself who was molested by her uncle, whose parents are divorcing, who just lost the only example that she has of love, who has sought refuge in drugs and alcohol, have a muzzle put on her mouth because she just saw Miss USA be shamed on national television for being sick. I wasn't a bad person trying to act good. I was a sick person that needed to get well. And that was the fire that started my journey to advocacy. I knew that there were so many people out there that were suffering just like me. And I suffered for most of my life because I had no idea what it was that I was suffering from. I was so excited to get out there and share my experience with what I had learned in treatment because I really felt like I found the pot of gold at the end of the rainbow, right? Addiction is one of the top healthcare issues in this country, and it kills more people than diabetes, heart disease, and cancer combined. There's an airplane full of people dropping from the sky every single day, and it's the most underfunded healthcare issue. People are being incarcerated for being sick. 80% of inmates suffer from substance use disorders, and almost half of them have been locked up for drug-related offenses. They don't need to be held captive. They need long-term recovery. Thank you. In schools where our children spend the majority of their time, there's no government-funded effective prevention program out there. And addiction starts in adolescence. Science tells us that prevention and treatment work. It's estimated that substance use costs our society around $442 billion a year. If more people had access to treatment, and if there were better prevention programs mandatory that were in place, we could take a chunk out of our national debt. We don't need to lock people up or build a wall. The drugs are already here. I found mine in my parents' medicine cabinets. In November of last year, the U.S. Surgeon General made an unprecedented report on drugs, alcohol, and health. And he issued a new call to action. There are currently 20 million Americans that are struggling with addiction, far more than those diagnosed with cancer, and only 10% of them will receive treatment. We all love to sensationalize the problem. I've been guilty of it, right? But rarely do we hear that Miss USA just celebrated 10 years of sobriety. Thank you. Dr. Vivek H. Murthy said that how we respond to the addiction crisis is a moral test for America. There are over 20 million people in long-term recovery. But what? I mean, I will share my dirty laundry to whoever will listen, but I challenge those who are in long-term recovery and all of the families whose lives have been recreated because of recovery to join together and recover out loud. Then maybe we can take the shame away from those who are in the shadows and encourage them to step into the light. I know I will. Thank you.
One of the takeaways from this, again, just kind of remember too, again, all the risk factors she talked about, again, having been molested at an early age, experiencing the death of a loved one, and not necessarily having the support system that she needed at home. So again, all these things we consider risk factors when it comes to women. Brain not being fully developed, and again, for any teenager, typically the brain is not fully developed until the age of 26. So again, that's a quick kind of overview of women. Now we're going to move on to African Americans and Latino and Latina individuals. So again, hmm. So most research on substance abuse among Hispanics and Latinas, again, is typically only focused on alcohol, so not necessarily other illicit substances or other behavioral type of addictions. Again, regardless of our national origin or of their national origin, Hispanics and Latinas generally have higher rates of abstinence from alcohol and drink alcohol less frequently than Hispanic or Latino men. So again, when we start looking at breaking it down by gender, women tend to drink less than men when it comes to this particular demographic. Some of this is due to, again, some of the cultural differences, some of the gender roles, and again, the cultural sanctions against drinking by women. So again, this is really why we see that. So again, growing up, again, that machismo, and again, women being more maternal and expected to behave in such a way. So some of it is gender-based and gender role oriented. Hispanic population is going to include Mexican, Puerto Rican, Cuban, Salvadorian, sorry, and Dominican. Racially, Hispanics are white, Black, Indian, or some combination. So again, we look at like census bureaus and things of that nature. Again, how they actually identify can vary. So just because, again, you see someone, they may not necessarily racially identify the way you think they do. Hispanics have a third highest percentage of drug use and the second highest of heavy alcohol consumption when compared to the total U.S. population. 45% is going to be use of alcohol, which is the most frequent. As noted before, males tend to drink more than women, and consumption increases with separation or divorce. So again, that's still some of the same risk factors that we talk about as it relates to women. And again, this is kind of across all genders or all cultures. Higher rates of acculturation are correlated with higher drinking levels. So again, when we talk about acculturation, primarily that it's not assimilation, but again, that idea that you still try to maintain your cultural heritage, but also still try to assimilate or take on some of the dominant culture expectations, so to speak. So again, trying to kind of code switch between the two. Those individuals who were actually born in the U.S., so again, first generation U.S. Born, they tend to have higher rates of alcohol use, binge alcohol use, and illicit drug use. And this is really because more of assimilation, again, maybe a little bit of rebelling towards one's own culture and then trying to mostly assimilate in with the dominant culture. Hispanic youth is one of the largest and fastest growing populations, so drug use can be magnified by difficulties associated with cultural expectations, socioeconomic issues, and linguistic pressures. And again, this idea to speak English, to also do a lot of translating for your family. So again, just having to learn both languages. Some risk factors, again, exposure to immigration, acculturation, discrimination, language barriers, and disruption in their social system. And again, disruption can look like obviously a death in the family, incarceration, or possibly deportation. Environmental factors can include greater access. So again, there's a lot more alcohol or liquor stores in more poor urban neighborhoods. You tend to see, again, this reminds me of the scene of Boys in the Hood where, again, I can't think of Lawrence's character's name, but again, he's having them look and talk about how many liquor stores on every single corner within their neighborhood. And again, this is not, it's by design. Greater availability of illicit drugs, again, higher unemployment rates, and then higher poverty rates. Again, unhealthy coping mechanisms. So again, not being able to actually cope with the stressors that come along with everyday life. When we move over to the African Americans, again, this population has a higher risk for behavioral health issues than many other race demographics because of social and economic factors. Again, according to the APA, nearly 1/4, 22% of the African American population, they live in poverty, with many who are incarcerated, homeless, victims of violent crime, or have or our children in the foster care or child welfare system. So again, there's a lot of different moving pieces. And again, this all goes back to when we talk about intersectionality on day one. You know, when you look at an individual, you have to look at them holistically. You can't just see the person that's sitting in front of you. You have to kind of pick them apart and see all the different things that are impacting them and why they are behaving the way they're behaving or coping the way that they're coping. African Americans, as they age, they contract more alcohol-related diseases than any other group in the population. Again, the age-adjusted alcohol-related death is 10% higher than the rest of the population. When we talk about the introduction of crack cocaine, which happened in the mid-'80s, it impacted, of course, crime. We talked about this in terms of causing a lot of disruption in families. So again, this became the highlight of like incarceration, as well as individuals who became addicted, either overdosed and died, or again, they just left, became homeless, and again, just kind of left the family. And of course, this contributed to the increase of various diseases, which include HIV/AIDS, which was linked to the IV drug use. According to SAMHSA, again, which just publishes that the African Americans may suffer from a slightly higher rate of co-occurring mental illness and addiction than the general public. And again, this is 3.8% compared to 3.3. And again, it's not a huge percentage, but again, considering African Americans are only 13% of the population, again, that is a big difference. Co-occurring mental health and substance use disorders require specialized integrated care programs that can manage both the mental health disorder and the addiction at the same time. Alcohol is the single most widely used drugs by young African Americans aged 12 to 20, but consumption is less than young whites. And again, if going back to the video we just saw, again, the average age of drinking starts at age 11. In spite of the lower rates, African Americans show a higher prevalence for alcohol-related problems. The leading cause of death for African American youth, 12 to 20, homicide is unintentional injury and suicide. Marijuana remains the most popular drug choice for African American youth. This is a video as well, and I will tell you again, if you are triggered by anything needle related or again, drug related, actually, obviously I can't show it now because it's age restricted. But again, I'll put this on the Blackboard website for those of you who want to watch it. It's a really interesting video, and it definitely does a good job of talking about and addressing some of the stigma related to it, some of the barriers that individuals face. And while it's really focused on African Americans, you can look at the barriers, and again, many people are going to face some of these same barriers, whether it comes to like being on medical or medicine addicted, or I'm sorry, MAT treatment, so which is medical assisted therapy or treatment. And again, that's people who are taking blockers like I'm drawing a blank right now. But long story short, again, Medicaid or Medicare, private insurance, not necessarily paying for those medicines that are actually needed for those individuals. And I do apologize for blanking on the name of the medications right now. Again, some of the reasons and predictors of substance use disorders within this group, again, is racism, internalized racism. And if you remember from day one, we talked about different types of racism, structural, internal, internalized racism, again, one within oneself. So again, the social myths that we tell ourselves, or prejudices or stereotypes that we tell ourselves, even with we talk about, and we'll get to the Asian population when they talk about that model minority. So all these things play a role. And again, not being able to live up to certain things or succumbing to certain stereotypes. Interpersonal racism, again, repeated exposure to violence, so news, media, or social media. Sorry, guys, about the dog. New continued acts of violence. And then, of course, we talked about structural racism, which is, again, policy related. So like the war on drugs from the 80s, it continues to impact Black communities even to this day. Now we move on to older adults and addiction. Clinicians have not typically targeted them as an actual at-risk group. And again, there's not really a lot of research out there. And again, part of the problem is, adults are taking so much medication anyway, so it's really kind of hard to tell if there's an addiction issue going on. Again, these are just side effects of medication. So with older adults, alcoholism is considered a problem for both adolescents and younger adults. Again, detection screening assessments have been designed for the young. So again, we kind of ignore it because we feel like, again, alcoholism doesn't impact them, or they're allowed to drink socially, or, they've done their time. So, we shouldn't really bother them. So again, it's one of those things where we see it happening, but we don't equate it to addiction or binge drinking or a problem simply because of the age. And we kind of say, well, they deserve, this part or this time of their life. We also look at, again, like I talked about, detection, screening, and assessment. Typically, these things are designed, these tools are designed for younger people. And realistically, a lot of the research that we have is based on 21-year-old white males, again, college educated. So again, it's not really pulling the whole demographic of individuals who may engage in addictive behavior or alcohol or drugs, things of that nature. Like I said, detecting abuse is going to be harder just because of the other health issues that they have. And older people tend to live in greater isolation. So again, not a lot of people are checking in on them. You just kind of go on with your daily life. And if they live alone, again, they don't have necessarily access to other social avenues. So again, it's kind of a isolation thing, as well as, oh, well, we feel like they're fine and, they're doing okay. Alcohol abuse research in older adults by ethnicity is going to be inconsistent. There's a consensus that white older Americans have higher rates of alcohol dependence than older African Americans. However, lower income tends to have more problems. African Americans tend to have more problems. Older African Americans have higher rates of alcohol dependence when compared to ethnic groups. Alcohol use decreases with age among white Americans, but increases with age among African Americans. Hispanic females have lower rates than whites, and then older adults in nursing facilities are more likely to abuse or have abused alcohol when compared to those in the community. The physiological process of aging is a greater risk factor for alcohol abuse. So again, as you continue to get older, we also know there's certain things about, bone density, muscle loss, things of that nature. So all those things tend to have an impact on how they metabolize alcohol. So again, it increases their sensitivity. Age-related decrease in body water present an increased risk for intoxication. And again, older adults do not become more tolerant. Aging and alcohol dependence increases physical injury risk. More medications could have adverse interactions. Older women at risk for osteoporosis and those who drink are vulnerable to hip fractures. Here we have a quick video, hopefully.
PT reports. Aging matters. Overall, we're seeing higher rates of substance misuse and addiction among the senior population, particularly in the younger old, the baby boomers, those in their late 50s, 60s, and some into their 70s. They grew up during the 60s and used many different substances during that period of time.
My addiction started many years ago with alcoholism, and then I have progressed through the years into an opioid addiction.
After I retired, I often would get up and have mimosas or Bloody Mary. And again, once the morning drinking started, it just snowballed for the rest of the day.
Alcohol is still the most common substance that is abused by older adults, and that is often associated with other mental health conditions that they might have, like depression. So some may also be treating, depression with opioids. And there's certainly a clear link between depression and pain among older adults. And we found that about 1 out of every 1,000 Medicare beneficiaries, those over the age of 65, are at high risk for an opioid disorder.
An addict can look like me, smell like me, talk like me, and still be in their addiction.
There are a lot of people, especially with medical advances that we have today, that live a long time with substance use disorder. But even those who do, oftentimes they experience things that typically only happen to people that are older. As a person ages, their body changes. There's not as much fluid inside of an older human to dilute that, and they don't metabolize it as fast. So people become intoxicated faster. And so what maybe at one point wouldn't have been considered a use disorder or even risky use, for a person who's 50 or older, it becomes more risky.
So again, just a really quick video when it comes to older adults and addiction. So some other risk factors Again, we look at the aging process, physical and mental changes, life transitions, so again, grief and loss, again, a lot of their friends, loved ones, again, support systems. Also think about like retirement, right? Not understanding or having a lot of things to do in retirement. So again, that's those other losses. Depression is common later in life. Prescription medication for legitimate medical needs. Again, alcohol-related traffic accidents. The older adults, the fastest growing segment of the driving population. And again, we look at some genders. Older men are going to be more likely to drink versus women. Now we're going to hop over to the LGBTQ plus population and addiction. So again, we look at this particular community and they suffer from the higher rates of substance abuse, partly due to socially created obstacles. So this can be obviously discrimination, stigmatization, again, based on their sexual orientation, hate crimes, emotional abuse, threats, public humiliation or ridicule, rejection from family and friends, shame after they come out, a loss of employment or not receiving promotions, internalized homophobia or self-hatred. And then, of course, they also suffer from co-occurring disorders, which include major depression, generalized anxiety disorder, suicide attempts and other self-harming tendencies, and then higher levels of stress. So lesbian women and gay men are typically overrepresented in rates of substance abuse. Again, the number of gay people in general population is not known. And this is primarily true. Again, nobody really knows. It's not like there's a census that goes out and asks. And again, a lot of people aren't telling simply because of there's still a stigma and a shame related to it, to identifying in that population. So again, it's almost back to when we talk about, I think, Army days prior to, I think it was Obama during the Bush administration when it was don't ask, don't tell. So some people still have that mentality. Some studies show that lesbian gay participants reported more problems with drug use across all classes of drugs compared to heterosexual individuals. Again, marijuana is going to be the most commonly used drugs, which is very similar to that of African-American youth. Homosexual participants were more likely to meet the criteria for dependence, not necessarily addiction. So again, there is a difference. Again, gay adolescents are also identified at a higher level of risk for substance abuse. Adolescents are more likely to abuse hard drugs than marijuana or alcohol. For some gay men, sexual compulsivity is also concerned with substance abuse. So again, they may have a higher risk factor of HIV/AIDS. And again, this is still that dual diagnosis. So again, there's a difference between a co-occurring disorder, which is another like a mental health disorder along with addiction. But again, now we talk about a dual diagnosis. Well, technically, when we talk about dual diagnosis, it used to be, that used to be the term that we use versus co-occurring disorder. But again, you can have multiple addictions and still fall under the dual diagnosis. The desire to be masculine or have the perfect body plays a role in substance abuse for gay men. So again, still some image issues. And again, just looking out for the types of drugs that they're using, again, methamphetamine, things of that nature. Lesbian women may also present with histories of sexual abuse, relationship violence, levels of stress, job-related concerns, and depression. Gay men tend to use more alcohol. Lesbian women are no more likely than heterosexual women to abuse alcohol, but they are greater risk of using other drugs. Then we want to look at some of the why behind this. And again, we look at the social learning theory. And again, while the LGBTQ plus population are not confined to bars and clubs like they have been in the past, but again, gay bars remain one of the main social outlets in the community. So, if this is seen as like a learned behavior. So again, it's that idea that this is socially acceptable, and to be accepted, and I'm looking for acceptance, then I need to engage in this behavior. Some other populations just to look at, again, we look at Arab Americans, and again, some of the risk factors include trauma, loss and grief. The research, of course, is limited, just like we would with like older adults, and again, that in the LGBTQ plus population. So again, access and denial for cultural implications. So again, you want to make sure that you are, again, making sure that you're looking at the whole individual. We look at Asian Americans and Pacific Islanders. So again, microaggressions. So again, some risk factors we need to look at. Racism, so systematic, interpersonal, internal. There's also stereotypes of social submission, emasculation of boys. And then with the COVID-19 pandemic, it increased the hatred and violence towards this particular population. We look at Native Americans, and again, Native American adults have higher higher rates of nicotine and substance use disorders. Youth experience SUD at an early age. Opioid misuse increased in 2018 for 12 to 17-year-olds, and it decreased for other age groups. Native Americans experience more ACEs, which is that adverse childhood experiences versus the general population. So again, we talk about having experienced 5 or more traumas as a child tends to increase the likelihood of your addiction later on in life. Social ecological factors like poverty, homelessness, domestic violence, and violent crimes are being subject to violent crimes. Again, other populations, we look at adolescents and young adults. Like I said, this is diversity. So again, diversity does not just include race or ethnicity. So again, we have to look at age. So again, adolescents and young people have an increased risk linked to individual, so their biology, again, community and family and societal things. Adolescents and young adults tend to have belief it will not happen to them. So again, they have this invisibility ideology, which is why they're more risk takers. They believe they have the physical ability to bounce back, or again, even if I do become addicted, I can overcome it, or, it's not going to happen to me. As we noted in the video, again, their brain is not fully developed. And then we look at people with co-occurring disorders. Again, untreated psychological issues tend to be the biggest population. Again, so people are self-medicating because they've never been diagnosed with a mental health disorder. We look at unemployment and housing instability for individuals who have a mental health disorder. Age is a risk factor for this group. Again, we have a higher number of personal stresses. So again, this could be financial loss or involvement in the criminal justice system. Speaking of criminal justice system, again, looking at this particular population, like I said, diversity goes beyond race and gender. Again, what if you have a criminal record, or again, what if you have any type of affiliation with the criminal justice system? We do know that there is a link between substance use and crime. It's not a, causation. So again, just because you engage in substance use or alcohol use, you're going to commit a crime, but there is a link. Issues related to education, employment, and mental health influences the likelihood of criminal activity. Again, if you don't know, typically we are building prisons based on 3rd grade reading levels. So again, education is a high predictor of whether or not individuals are going to end up in prison. And again, for those of you who are interested in additional research, it's been coined the school to prison pipeline. This is a very popular not because it's good, but popular because it's been something that's been studied quite a lot in terms of research. We are failing people at the academic level, early grade school. Even right now in Michigan, we still have some of the lowest 3rd grade reading rates. And again, that's really what we're basing a lot of our future crime stats on, is those reading rates. Again, we mentioned ACEs, which is the adverse childhood experiences. So again, typically there are individuals in prison who have meet a lot of the criteria for having an adverse childhood experience. And individuals with disability. Again, this is a population that probably also goes overlooked, just like with the older population. Again, there's misidentification. The focus is on the disability of the person. So again, they miss the warning signs related to a substance use disorder. And again, this is why it's really important to kind of dissect the individual piece by piece. Again, that intersectionality, they're not just, a male, they're not just female, they're not just white, they're not just young. They have all these different identities that we have to address. Higher use of prescription medication, higher rates of unemployment and poverty. They have increased risk of physical and sexual abuse, and like with older adults, again, increased isolation. So that kind of goes over not necessarily all the diverse populations, but again, it gives you a good idea of the different types of diverse populations and some of the risk factors. Like I said, you really want to dissect the person individually when you are starting to do any type of assessment. So now we kind of move on to treatment. Again, there's a couple different worldviews. Again, you have a holistic worldview. Again, when we look at holistic, we want to look at holistic ways for treatment. So again, what does the nature say? What does spirituality say, right? So we're not looking at the traditional Western medicine type things of healing. So again, becoming healthy involves more than just the individual It entails reconnecting with the larger universe, and again, spirituality. And again, beliefs and ceremonies often are central to clients from some cultural groups. So again, this includes Hispanics and Latinos, as well as American Indians. Spirituality should be recognized and considered during treatment. Again, just because that's not your cup of tea, you don't want to deny that for an individual, and they need that as part of their recovery. There's the community orientation. Again, so white America really assumes that treatment focus on the individual and the individual's welfare. Some cultures instead are oriented to the collective good of the group. So again, Asian Americans, Native Americans, they care more about how the substance use disorder may harm their family group and how they are affected. So again, this goes back to the stigma and shame. It's also a barrier to them getting treatment when we talk about Native Indians as well as Asian Americans. I'm sorry, Asian Americans and Native Americans, because again, there's so much emphasis on family and respect of family and honor of family that again, it's the idea, and like in many cultures, ethnic cultures, Black community, Asian community, Hispanic community, like you don't share your problems with the outside world or with strangers. So again, that's another barrier. Or again, typically in Western and the dominant culture. So again, the white culture, it's, therapy's okay. We should talk about our struggles, right? We should get help. Seeking help is okay. So again, there's that difference. Extended families, the U.S. nuclear family consisting of parents and children is not what most other cultures mean by family. So again, you may need to involve other people within their treatment method. This could look like, play cousins, play aunties, if they're in a tribe or, they live on tribal land. This could look like other individuals from different tribes or different communities. So again, just making sure that you're looking at all their family. Some issues impacting treatment, again, boundaries and authority issues. Clients from other cultures often perceive the counselor as a person of authority. So again, this can lead to the client and counselors having different ideas about how close the counselor-client relationship should be. It's the idea of, again, I don't trust you. I don't know you. I don't trust you. You don't look like me. I don't trust you. So again, just making sure that rapport building is part of that. And this is why we also say that the assessment and treatment plan can be changed, because as you continue to work with individuals, you gain more information, you become more and more they become more and more open with you, and again, are starting to give you more and more information, and you can do a better job of providing treatments that are going to be more holistic. Respect and dignity for most cultures, particularly those that have been oppressed, being treated with respect and dignity is supremely important. Again, so we talk about white culture tends to be informal and how people are dressed. Again, this is kind of a pet peeve of mine. Again, a lot of people like to call me by my first name. I don't know you. We're not friends. We're not colleagues. So again, if we are unknown to one another, again, typically you're going to address me by my last name or at least my professional name. And again, this is the same thing working in a prison. We only address prisoners by their last name. This is also a safety issue, but even going into parole and probation, right? I never addressed individuals by their first name. It was always Mr. So-and-so, Miss So-and-so. It was never a first name basis because again, it's a respect thing, and also just understanding that this is a professional relationship, right? And you want to set boundaries and make sure people understand that, you're not friends. This is not a friendly environment. This is a professional environment. So those things really do matter. So again, just making sure that if that is how you're doing your treatment or how you are interacting, that people know that that's a boundary. But again, if you are somebody that just likes to be informal, just understand that some cultures don't believe in that, and that's okay, and just be okay with that. So just be flexible when it comes to this particular piece. Attitudes towards help from counselors. Again, there's a wide difference across cultures concerning whether people feel comfortable accepting help from professionals. Many cultures prefer to handle problems within the extended family. So again, on our own, within the church, within the community. So the clinician and client also may have to harbor different assumptions about what a clinician is supposed to do and how a client should act and what causes the illness. Mistrust of authorities. Immigrants and refugees from many regions of the world feel extreme mistrust of government based on the, again, like war crimes, things of that nature. Again, fear of deportation by the U.S. So again, this mistrust can be a barrier to entering treatment and to obtaining services. Again, we're in a political climate now where if you can't produce papers, even if you are a citizen, you still may be detained. So again, just the fear of that is going to prevent another barrier for individuals seeking any type of help, especially help with addiction. And it also puts a damper on a lot of facilities in terms of, you know, what you're capable of doing, what you have to report, especially if you're getting federal funding. So again, what are you mandated to do? You know, do you have to comply with federal government just for your funding, or again, is HIPAA still in place? So this is going to be a very interesting time to kind of navigate through and what that's going to look like. Because again, there are some agencies that have, you know, hey, we don't care about your status. We don't care about anything. You know, we just want you to come in for treatment. But if I'm federally funded, like what are my obligations? And then what are my confidentiality? What am I ethically obligated to do? So it's going to be a very interesting time. Extreme sense of stigma. Clients from other cultures view mental disorders, including substance abuse, as more negatively than, again, the U.S. population. In some Asian cultures, again, the stigma is so strong that the person's substance dependence is thought to reflect poorly in the family lineage, again, diminishing the marriage and economic prospects of the client. So again, we may think like, hey, you know, asking for help is great and you shouldn't feel ashamed. But again, depending on an individual's culture and the expectations, it could be an extreme barrier for them. Some barriers for women. Treatment is traditionally going to be male-oriented. Again, we have stigma, shame, and guilt attached to the disease. Friends and relatives may be obstructive rather than supportive. Doctors and counselors are going to be less effective in diagnosing women versus men. Women tend to have more obligations to children and family and work. So again, they may not even seek treatment because of these obligations, especially if you have a single parent. Laws related to substance abuse and pregnancy is also a barrier. Again, oftentimes if you are a substance abuser and you're even trying to seek some medical assistant treatment, again, they may be calling CPS. So again, you have to think about all these different things. Economic concerns, again, single women, single parents, and poverty, unemployed, partner relationship issues precipitate relapse for women. So those are just some barriers. Some barriers for Hispanics, again, strong cultural beliefs against substance use for Hispanic women, as well as beliefs against sharing their personal problems with a stranger. Lack of sensitivity to cultural beliefs, norms, and practices result in poor treatment outcomes. So again, that's the practitioner not bringing in cultural appropriate treatment and interventions, not acknowledging culture and how it plays a role. Treatment requirements or traditional treatment often require one to adjust more to the dominant culture. So again, it's just kind of, once again, saying that we really need to be cognizant of one's culture, what they want, what they think is important, and what's going to lead to better treatment outcomes. Again, we have to understand that substance abuse problems are going to be multidimensional. Again, bilingual family-oriented perspectives that look beyond the symptoms. Some barriers for African Americans, again, systematic barriers like the criminal justice system, incarceration versus treatment. Again, like we mentioned with the war on drugs, oftentimes, you know, individuals who were Black tend to be incarcerated more so than white counterparts. And again, this is still true today when you think about, you know, some of the laws, you know, the crack versus powder cocaine, you know, heroin versus opioids, you know, it's all an addiction, but again, the treatment is typically seen as different. So again, poor and minority individuals tend to be incarcerated more so than the white dominant culture when it comes to the same types of offenses. So yeah, it's just very interesting at how that looks. Lack of employment, housing and insurance, and then cultural implications. Family matters are supposed to stay within the family. Barriers for those in the LGBTQ plus community include just the need for safe space, lack of training in the mental health field, so what constitutes family, and then professional titles can be counterproductive. So again, if you are a marriage and family counselor, again, you may or may not, you know it, but again, you're kind of, it's creating a barrier for individuals who may be in the LGBTQ plus population. And again, going back to, you know, where we are in a political climate right now with, you know, federal funding, there's already a lack of space for individuals within this community. But again, our agencies now going to be even less funded or less obligated to help the community, those individuals who identify in the LGBTQ plus community. So again, this is going to have some very interesting effects in the next couple years in terms of how we look at this research, you know, what addiction is going to look like. Is it going to increase co-occurring disorders, you know, lack of availability of treatment, things of that nature. So again, it will be interesting to see in the upcoming years. Some barriers for older adults, most significant is that substance use disorders are unrecognized and underdiagnosed. It may contribute to the aging process. So again, sleep problems, memory problems. So again, this is why they're having these issues. Nobody thinks that, hey, they're just old or they're taking some medication. These are the side effects. Nobody ever asks, hey, are you drinking? Stigma and fear associated with substance use disorder in older adults, structure and programming of substance use disorder services and facilities. So again, in 2019, only about 23% of all facilities reported having program for the older population. So some screening and assessments, again, that you can use. Again, TWEAK is optimal for use for women. Effectiveness varies by ethnicity. Answers of 2+ or more indicates a problem. We have the CAGE and the MASS-G, which is the Michigan Alcohol Screening Test Geriatric. These are both approved for older adults. So some of the questions include like, does drinking help you sleep? We have the SMAST, so SMAST-G is the shorter version of the MAST-G. And then we have the short form geriatric depression scale, which is the GDS. It's an effective screen for depression in older adults. A lot of these screening tools are going to be available online, but some of them you do have to pay for. So again, we look for cultural screening and assessments. Again, we want to assess the client's primary language and language proficiency prior to the administration of any evaluation or testing instrument. So this is where, again, we talk about being inclusive. We want to make sure that we have screening tools that are available in a variety of languages, simply because that's ethically appropriate. We also don't want to rely on family members to do any type of translation for us, because again, we don't know what they're saying is actually accurate or true. So we don't get a true understanding of that. So again, if we don't have those types of tools available to us, meaning screening tools in the right language, then we also need to make sure that we invest in interpreters. And this is something that, again, we don't necessarily address in this particular class, but again, we talk about language barriers. But again, those individuals who are who use sign language, who are hearing or deaf, right? And they need sign language. So again, individuals who have low vision or other vision issues, again, making sure we have things like Braille. So yeah, there's a lot of things that we need to address when it comes to, or being inclusive when it comes to, again, our treatment. Determine whether the assessment materials were translated using specific terms, including idioms that correspond to the client's literacy level or culture or language. So again, just understanding there's a lot of things out there that are getting more westernized and again, may not translate to another language, even if we try to translate it. Do not assume that translation into the stated language exactly matches the specific language of the client. So again, specifically, the client may not understand the translated language, again, if it doesn't match their way of speaking. So just be aware of that. Treatment service for the Hispanic and Latino population should be culturally sensitive, include language translation when needed. Families should be included in treatment and recovery. Again, large families are often part of the person's home environment and daily social circle. Addiction treatment programs may be optimal when they are gender specific and cater specifically to the Hispanic population. When we look at African Americans and treatment, again, addiction treatment considerations for this population will need to also be culturally sensitive, address maladaptive thoughts and behaviors, teach stress management techniques, and focus on co-occurring and mental health and medical issues. We have a video here. You can look at this later, and I'll put it in Blackboard. But again, Afrocentric acceptance and commitment therapy. So this is AACT. It's a specific type of therapy that is specific to African Americans, and again, specifically African American males. Appropriate self-disclosure may increase trust. So again, making sure that you're using disclosure or self-disclosure appropriately, not for your sake, but again, for the benefit of the client. Do not assume that racial identity and cultural values are a source of strength. It could be a source of pain. So again, making sure that you really do a good job in assessing your client and getting to know them and find out what's important to them. We look at some types of treatments and interventions. Again, brief interventions. These are going to be practices that aim to investigate a potential problem and motivate the individual to change. It's not used for those who have a high level of dependency. So again, people who have more severe levels of substance use disorders. Again, this is not where you start. This is people, maybe they have a dependence again, they haven't necessarily gone over to addiction, or maybe there's a concern. So again, you're doing a brief intervention. Can be used to engage clients who need specialized treatment. We have the FRAMES method, which is feedback about personal risk or impairment, responsibility for change placed on participant, advice to change given by clinician, empathetic style used by counselor, and then self-efficacy or optimistic empowerment is engineered in participants. Other things, some goals of brief interventions is to reduce risk of harm. So brief therapy is systematic, is focused, is processed. Again, it relies on assessment. So again, this is why things like our interventions can change, because assessment can change. We need client engagement and rapid implementation of change. It can be done in 1 to 40 sessions. Again, goals are to provide clients with the tools to change basic attitudes and handle a variety of underlying problems. And again, the focus may be on the present. This can be standard care for all populations. It can be used in dual diagnosis. The duration of substance dependence, again, type and level of influence from peers, level of motivation, and availability of familiar and community support. So again, brief interventions are very effective, can be used with a wide range of populations, but again, just understanding that it's not necessarily intended for people who have severe substance use disorders. Again, stages of change. This may be familiar to a lot of you. Again, we talk about the transformational changes. So trans-theoretical model of change. Stage 1, pre-contemplation. Again, I'm not really thinking about change. Many people seen in primary care who score positive on the assist. Again, that's another tool that we can use, are likely to be in the stage. They're happy users, so maybe social drinkers. They do not have any worries about their use of psychoactive substances and do not want to change. And again, this could be somebody who smokes marijuana on a regular basis. Or again, you have some people who are just casual drug users, right? Everybody who uses drugs doesn't necessarily mean that they aren't addicted to that drug. They may not know or accept that their substance use is a risk or problematic. People in this stage are unlikely to respond to advice to change their behavior, but may be receptive to information about the risk associated with their level and pattern of substance use. So we want to provide information that may encourage them to recognize the risk of substance use and to think about cutting down or stopping their substance use. This could look like using some motivational interviewing. What would happen if you think you would stop drinking, or if you cut back, how would things change? Would your life be better or worse? Things of that nature. So stage 2, thinking about cutting down or stopping substances. Again, this is the contemplation. So people in this stage are going to be likely to be ambivalent about their substance use. They can see both the good things and not the so good things about their substance use. So again, it's like, it's like me and cookies, right? And Oreos. Like, I know I shouldn't be eating them, but the reality is I like them. They taste good going down, but at the same time, I know there's no benefit to them. So again, it's kind of like a catch-22. Again, they have some awareness of the problems associated with the substance use and maybe weighing up the advantages and disadvantages of their current substance use patterns. Others may be willing to make change, but they may not know how to make the change. So again, I know I need to cut down on my cookie take, but when the Girl Scouts keep knocking at my door, I don't know what to do. So again, have to maybe give them some ideas. They may not be confident that they're able to change. Maybe they've gone a day or two, but again, that's pretty much it. So again, their confidence level is not where it needs to be. And this is what we need to talk about with them. It's kind of like that harm reduction approach, right? Even if they go an hour, right? If you're able to go 24 hours, or 6 hours, whatever that looks like, we want to give small goals, right? In order for them to build up that self-efficacy that they know they can actually make a change. So again, when we talk about recovery doesn't have to be all or nothing. So again, we look at interventions for people in this stage, focus on providing information about their substance-related risk, advice to cut down or stop, and helping them to talk about the good and not so good things about their current substance use pattern. The aim here is to encourage them to find and talk about their own reasons to cut down or stop their substance use. So again, this goes back to motivational interviewing, what things would look like if you didn't. So, hey, if you stop eating cookies, like what are some of the benefits of stop eating cookies? Well, maybe my face will clear up some, right? I won't feel as sluggish after I eat the cookies, right? Maybe I gain the weight or lose some weight. So again, you have to talk about what are the benefits of not eating the cookies, or in this instance, substance use. Ambivalence about substance use includes the benefits to the patient, the current substance use behavior. and the cost associated with changing. So again, some people don't want to stop because maybe they lose their friends, right? They have to have a new set of friends. So this is what they do in their social circle, or maybe it's their social circle that's encouraging them to continue this behavior. While the other sides are costs of current substance use and the benefits of change. So again, what's the reason for change? Change is unlikely to occur until the reasons for change outweigh the reasons for staying the same. Stage 3 is doing something about changing the behavior. So this is the action stage. People in action stage have made the decision that their use of substances needs to change. So again, I'm doing something about it. This may be abstaining or cutting down. They have decided to change their established behavior. People in this stage are likely to continue to feel ambivalent about their substance use and need encouragement and support to maintain that decision. So this again is where people might be in a support group like AA or NA, right? Because again, that provides them a different support. Maybe they're not ready for, any other type of group or individual therapy, but again, maybe they can do that. Interventions for this stage also include negotiating aims and goals for changing risky substance use behavior altogether, suggesting a range of strategies that they could choose from to help them cut down or stop their substance use. So again, what are some different things that you can do? And again, I know we've been talking about addiction in terms of substance use and alcohol use, but again, this could also be used with, smoking, tobacco, right? Vaping. There's a lot of people who want to cut down on their vaping. So again, what are some things that you can do other than vape, right? So what does that look like? And coming up with strategies that the client is willing to do, and they agree to. And this is something that's simple for them to do. Because again, you don't want to give anybody something that can't do, because then it impacts their self, ability or their self-efficacy. Like, I fail and I couldn't do this, so therefore I'm not going to be able to maintain my sobriety. You want to help them identify situations where they might be at risk of relapse. This can look like role play. What are you going to do when you go to the club or when you go to this party, especially when you're working with individuals and they may come to you and say, hey, I have this big event coming up. The expectation is everybody engages in, drinking, what can I do? And it's honestly, you can role play the situation, right? And help them navigate various scenarios or various strategies to get their way through it. Discussing with the patient their plan for action to reduce or stop their substance. Again, this also reminds me of an episode of Mom where I think Tammy, who was the one who got out of prison, she was going her first date. And she's like, what do I do if we ask for drinks? And they're like, it came up with all these different scenarios that, she could come up with, because her concern was, I don't want to tell them like I'm in recovery or anything of that nature. So again, you want to role play those situations for them so they become confident in being able to address the social stages. Stage 4, we're going to look at maintenance. So again, how do we keep the new behavior? This person is attempting to maintain the behavior, changes that have been made. This is where long-term success remains in the stage. And to be fair, just so you guys know, again, we look at these various stages. This is not a linear phase. So you don't progress 1, 2, 3, 4 through these stages. You may start in pre-contemplation and get to the active stage even before you hit contemplation. You may be in active stage and end up back in pre-contemplation. So there's a lot of reasons as to why people don't go through these stages linearly. People who are trying to maintain behavior changes need affirmation that they're doing a good job and encouragement to continue. Primary healthcare workers can assist people in this stage by providing praise for successes and reinforcing the patient's strategies for avoiding situations where they are at risk of relapse, or helping them to move on after a small lapse. And this is the other thing to understand, even if individuals lapse. So a lapse is usually a one-time thing. Again, we have to give everybody grace and let them know that's part of the recovery process. Part of the downfall of recovery and treatment is this abstinence idea that, if you use, you fail. And the reality is most people go through, this is a process, right? It's an in and out process. It's not just, some people are great at doing things cold turkey. They can do it cold turkey, and be great at it. But other people, again, they go through various phases and stages, and we have to recognize that. And then we have to encourage people to be forgiving of themselves and provide themselves some grace and let them know that this is part of the recovery process. And it's not that they've done anything wrong. How do we learn from this? So relapse, like I said, most people who try to make changes in their substance use behaviors will go back to substance use, at least for a time. Again, it should be expected For smokers, for example, they make an average of 6 attempts to quit smoking tobacco before they're even successful. Having relapse, they will return to one of the preceding stages, so pre-contemplation, contemplation, or action. For many people, changing their substance use gets easier each time they try until they eventually are successful. Some other interventions. We talked about 12-step facilitation. Again, AA, cognitive behavior, so CBT. I've mentioned motivational interviewing a couple of times, the matrix model, and then there's community reinforcement and contingency management. So CBT, again, solution-oriented form of talk therapy. It rests on the idea that thoughts and perceptions influence behavior. CBT is going to be appropriate for people of all ages, including children, adolescents, and adults. It can be used to address addiction as well as those with occurring disorders like anxiety and attention deficit disorder, bipolar, obsessive compulsive disorder, eating disorders, and post-traumatic stress disorders. The one thing I will say, and I don't think we've really identified this enough, typically when you are screening someone for a substance use disorder, you should also be screening them for another disorder, particularly an eating disorder or a gambling disorder. 12-step facilitation, again, therapy and active engagement strategy designed to increase the likelihood of substance abuser becoming affiliated with and actively involved in a 12-step self-help group process. We all know that the 12-step process or self-help groups, again, are typically facilitated by individuals who are in recovery. They provide a lot of support. People tell their stories. Again, there's really not a lot of professionalism or, again, people with license or credentials that are leading self-help groups. Not that they can't, but again, that's not necessarily the norm. Again, 3 ideas. We talk about the idea of acceptance, right? And that's why people like these groups because, again, they can be accepted. They can learn from other people in their situation. That's one of the things about addiction treatment, where a lot of individuals tend to struggle when it comes to being a therapist or being in individual counseling, because oftentimes people who are going through recovery want someone who've actually been through what they've been through in order to kind of connect on that way. It talks about surrendering, again, which is giving oneself over to a higher power. And again, one of the issues with 12 steps, again, for a lot of people, and again, even in the jail system, we have to also offer the SMART recovery as an alternative, because technically this is still a spiritual or religious type of treatment, or has that one piece. So again, if you have individuals who don't necessarily subscribe to that religion, again, you have an alternative for them. And then action involvement, again, you have all the different 12 steps that you go through in order to get to your recovery phase. Motivational interviewing is a counseling approach in which clinicians use a patient-centered stance paired with eliciting techniques to help patients explore and resolve their ambivalence about changing their behavior. So essentially what we're doing here in motivational interviewing is trying to find out what motivates you to change, or what is going to motivate you to change. And that involves asking a lot of questions, right? But asking specific questions in the right way, not just, peppering question after question after question to where your client feels like they're being interrogated. But again, you want to make sure that you are asking questions about the why, what's the ambivalence, or, what's the rationale for not, how is drinking or using drugs, how is that helping them, right? Why do they feel like it's necessary? Why is it such a positive thing in their life? And again, getting them to understand, because you want them to make the decision to change, not you kind of force that decision on there. This is why we talk about it being collaborative, right? It's autonomy. They get to decide whether or not, hey, I'm ready to make this decision or not, right? So again, we want to build awareness. It's a little bit of gentle confrontation, because again, at one point we're going to say like, hey, how is this, behavior helped you? And then they'll talk about it, and then you can confront and say, well, was it helpful when it, destroyed your marriage, or when you got the DUI, or whatever that looks like, right? Some key processes in motivational interviewing include engagement, focusing, evoking, and planning. We use motivational interviewing to build rapport, to engage the patient with a warm, non-judgmental attitude. Again, they elicit the patient's ideas and feelings about a range of current behaviors and how they fit with the patient's hopes and values. Like, again, to go back to eating the cookies. If I say I want to lose 10 pounds, but yet I'm eating cookies, well, how is that helping me lose 10 pounds, right? Now, if I say, I found a really healthy recipe for cookies, and I've swapped out my store-bought cookies for these cookies, okay, well, that's part of the change process. So that is the lecture for this week, or for this particular session. If you guys have any questions about anything, please make sure that you reach out.